We'll progress through these slides, which are also your notes, and you'll find I deal with some material in depth, some quite superficially. What I'm trying to create today is a way of looking at alters that's geared to understanding them as phenomena and a way that is applicable to most approaches to the treatment of DID. I'm going to present the fruits of clinical experience and clinical research, and it will not take any steps to be congruent except by mere chance with any major theoretical paradigm. Due to some family emergencies, references to reprints will be deferred to encourage your staying in the here and now, and also because I didn't get a chance to do them. Now, why do we take apart of parts? Initially, parts were considered central and quintessential to the work of DID, work with DID, and this was the case thousands of years before the emergence of considerations of process, which many people focus on pretty much exclusively today. In the modern era, an overinvestment in and fascination with parts was distracting. Fascination always is. But techniques were developed that allowed there to be work with these parts, and therapeutic results were good. In the 90s, primarily, there was a conservative backlash, false memory syndrome foundation attacks, and people ran from parts work like scalded cats, and they retreated from processing trauma to focusing on attachment and relational concerns. Now, lost in the dash towards these paradigms was the fact that these approaches based on the adroit application of techniques abandoned in haste by many actually led to more rapid and effective clinical results than any newer approaches have managed to achieve. What was promoted in their place is actually a worse track record. The newer paradigms dealt with this by non-citation of the earlier work. So what I'm trying to do today is make often bypassed knowledge and available and some new insights available to any clinician who wants to enhance knowledge of parts in order to improve clinical skills, regardless of orientation. Now, a word about states. It's a very complicated notion, states. We have ego states. Watkins and Watkins described an ego state as an organized system of behavior and experience bound together by some common principle, but it's separated from other such states by boundaries that are more or less permeable. If things are freely permeable if the boundaries across ego states in a person are freely permeable, that's normal. Minimally permeable boundaries are found in conditions like dissociative identity disorder. Now, Philip Bromberg, from a relational or intra-subjectivity perspective or interpersonal perspective, I talked to him last, he was using all three, used a definition of self-state, a highly individualized module of being, each configured by its own organization of cognitions, beliefs, dominant affect and mood, access to memories, skills, behaviors, values, and regulatory physiology. Now, interestingly enough, Bromberg's definition is very similar to the work of Watkins and Watkins, and Braun, and myself, and Kohut. I got a lot of people upset by saying, by criticizing all these state definitions, by saying all this stuff about self without acknowledging Kohut's definition of self as a center of initiative and experience misses the boat. If these different entities did not have different initiatives and experiences, they wouldn't have conflicts and they wouldn't be a clinical problem. I mean, that seems simple-minded rather than profound. So by, sorry, Heinz, I misspelled your name, Kohut. But really, the absence of taking Kohut's sense of self into account has led to an unnecessary degree of confusion between relational and other approaches to the psychology of DID. Now, if you read Bromberg's writings in great depth, self-state is essentially a relational concept. It's to be understood within an intersubjective context. Self in relation to other, then, is a state or place where a person is at a moment in the process, the relational matrix. When Bromberg discusses self-state entities, he evokes a sense of the ephemeral, being in the moment, entities that are not firmly fixed, but are always in the process of becoming. Uh, why do you want to work with alters even in the middle of process therapy? We have to be equipped to identify what's going on. And if you just go by association and conversation, a lot of this stuff just never comes up. A lot of gaps remain uncleared. You have to move towards a process that transcends dissociative boundaries. And actually, if you're just doing a process therapy, they can be avoided. That process can be avoided. I'll give you an example. Patient comes to me after moving to the University of Pennsylvania from another graduate environment, educational environment. I take a history and I say, well, it sounds like you're completely integrated according to what you've said. And that's fantastic. I'm glad to see Dr. So-and-so and you work so well together. And then I said, just for the heck of it, let's go through your life and tell me a little bit about how everything was each grade or each year or so. There were gaps all over the place. So I said, the patient, on the one hand, I hear you're integrated. On the other hand, there's so many gaps of knowledge. I have to wonder if maybe something was overlooked. Another personality comes out and says, you don't want to talk to them. Now, that's what happens when a process therapy is allowed to get lost in itself. So you need to periodically, no matter what your preferred paradigm is, check on it by using other paradigms of understanding. It's a good thing for the patient. When you're doing a structured kind of therapy, like using EMDR or cognitive behavioral or primarily supportive kind of effort, you want to field the right team for the right game. In other words, you need to know in that personality system which parts can work together to do the task that needs to be done. In other words, you don't want to say, oh, okay, we're going to abreact this trauma, that trauma, without mobilizing as much strength as you possibly can, without shielding other vulnerable parts from the abreactive process that others will be involved in, because otherwise you set off a chain reaction. And that is not a good thing. It's really a foolish thing, and this is always a temptation to me as an analyst to just go with the process. But I gotta know what's happening, especially if we're going into harm's way, like bad memories and stuff like that. I'll say, is anyone afraid of what we're talking about doing? And we'll talk about that. The ones that are afraid, can we put them to hypnotically to sleep while we're doing this, and others stand by protectively? Okay, it's useful. Do a lot of things to protect the process so it doesn't spread. You may find you're needing to work with parts that have trauma that needs to be processed, but they don't play a part in everyday life. You may have to be aggressively able to access them, at least assertively. And you may need to ask a lot of questions, which again, in a dynamic therapy, you're often not doing. How reacting and processing is important. And when you want to bring a session to an end, safe conclusion, again, you're thinking of reconfiguration. What do I have to put where so this person will be able to walk out of my office and be safe?